in back again. So
Into the
again,
mic,
I'm
Echo.
filling in for one of my colleagues who has to go for an emergency case. These panel discussions are mainly to generate an interactive atmosphere, and the main aim is for you to join in the interaction. This is the aim. We are just setting the table for that aim and objective. Just I will show one case where a 36-year-old gentleman, a real case which happened in our hospital, on telmisartan for blood pressure, 6 months, one recent onset dyspnea, dry cough for 10 days, goes to, of all the things, master health checkup. The usual myth. Many people think even if they have symptoms, they go for a master health checkup, the diagnosis will be through. He goes there. The usual possibilities any physician will know: recent onset cough, dry cough, and breathlessness. And this is what surprisingly the master health checkup clears him as perfectly normal, and he goes home with a tablet of some vitamin because some vitamin D was low. And the echo ECG, everything was normal. Recovering bronchitis maybe, cough syrup, and that's it. And then the next morning, this is what happens. He, while climbing stairs, he has almost fainting episode. Someone holds him up, and then he comes to the OP now. So these are common problems. Raju, we want to generate Aruna and Antony. See, you tell now. See, this is a big problem. Where is it that the mistake has happened? The echo, treadmill, ultrasound, everything was normal. Where would have been a potential mistake?
See, echo is normal. You're saying echo is normal, isn't
Yeah,
it?
that is
So
where potential mistakes. Can you clarify why echo can throw up mistakes?
Echo can be normal in case if the patient is obese, the window is not good. If you did not get a good PR signal or TR signal to assess the PA pressure, all this can cause a falsely low or a normal echo in patients with pulmonary embolism. But of course, history is very important. You are saying TMT has been done, which is normal. I don't know whether PFT has been done, that is important here. If all these are normal, then the commonest cause for significant recent onset dyspnea is pulmonary embolism.
So this is very important because of all these tests patients undergo in the health checkups, ultrasound and especially echocardiography are mind-based. They are subjective tests. They depend upon the person doing, while other tests are all objective. So whenever we see an echocardiogram, we know that we can't take whatever is reported as the truth. So this is the primary thing. In fact, many a time, in fact, every day at least 2-3 echo reports we send back for a review because clinically we know something else is there and this is not picked up. So this is the important thing. Don't go by whatever echo report is given by anyone. You have to check it again. If you go back to the history, of course, this gentleman had disproportionately severe dyspnea, severe persistent dry cough for 10 days. He lies down, cough, dry cough, that's all. There's no orthopnea as such, only dry cough. And then giddy episode when they climb upstairs or are having a bath and coming out, that is a very, very crucial harbinger of pulmonary embolism or any fixed output state, severe pulmonary hypertension or pulmonary embolism. This is what is likely. Pain, right upper abdomen, it says, of course, congestive, and you have to do the right test. Which test will you, Aruna, you go ahead. How will you take up this patient now?
Before doing the test, we have to do the saturation. We have to make the patient walk for some time, and we have to check the saturation. On exertion, if the saturation is coming down, we have to suspect pulmonary thromboembolism. And we have to do a CT with pulmonary PE protocol and also a D-dimer.
So, D-dimers, troponins, NT-proBNPs are all available as point of care in the OP, in the emergency room. D-dimer, in a case where you really suspect, it doesn't throw much importance, except that if it is negative, okay, the negative predictive value is good. Positive doesn't have many meaning because in unnecessary cases, if you keep doing D-dimer, many patients, sepsis, infections, everyone will show it. Negative predictive value is good. But the main crucial test is CT pulmonary angiography, which this patient undergoes. If you are in doubt, many a time we are asking for a double rule in, double rule out. You also look at the coronaries also. If the clinical history is not that clear, there will be some cases which we had, Antony, we know, inferior wall MI with RVMI and RV clot forms goes into pulmonary artery pulmonary embolism. Double problem. So a double rule in, rule out will diagnose these patients very well. And this is what this patient has. Multiple pulmonary emboli missed by an echo. So what we do is do an echo. If you can do, you do it yourself. This is what thromboemboli and Antony, these features, why you think initially they missed it? See, here obviously there is a dilatation of RARV, PA pressure is high, but as Raji was telling, TR signal was probably not good, so estimation of PA pressure is based on indirect methods. Can you elaborate on that?
Yeah, whenever they are doing the mastical checkup, their point of focus won't be there in a particular point. Whenever the clinician, as a cardiologist, whenever we are seeing with a complaint, we always focus some point. Like if it is a patient having dyspnea and exertional and giddiness and all, we will focus. Is there RARV, any dilatation is there or not, or severe PAH is there, or with RARV dilatation, it's not more than severe, only moderate PAH. We always keep a diagnosis of pulmonary embolism in that.
So even if the RARV are not dilated, pulmonary embolism cannot be ruled out. A negative echo does not rule out pulmonary embolism. A negative D-dimer might rule out. But here, why? Because only 50% of times you might pick up the findings. If it is there, yes, very important. RARV are dilated. Of course, you will, the other differentials like an acute RVMI and all that you will rule out. PA pressure estimation in the absence of TR is a challenge which a technician in the echo lab might not be able to answer. You have to take up. So this is definitely multiple pulmonary emboli with severe PAH, exertional presyncope. Obviously the patient is quite sick, 36 years. He has done a treadmill one day before without any problem, 5 minutes treadmill. So this is it. Once a DVT pulmonary embolism case is diagnosed, we have to think what are the things. Raju, can you tell about the source and the cause, how we go about in these patients?
Yeah, the finding the etiology for the pulmonary embolism or DVT is very important here. Usually it is, you can ask a detailed history of surgery or recent bedriddency or a long distance travel or family history of pulmonary thromboembolism, because especially certain conditions like factor V Leiden and prothrombin mutations can run in the family. So it's very important that we ask the history, family history of pulmonary embolism, then certain hypercoagulable states like protein C, protein S, antithrombin 3 deficiency, thrombocytosis. There are so many other conditions. So if from history, if it is not very obvious, please go ahead with doing all these tests.
So here the ultrasound Doppler bilateral lower limbs is a crucial test, of course. That is where most of the source is. But if you miss to ask for iliac vein assessment, you will miss many cases. That is one important thing. Arm veins in certain people, yes. Especially we have seen cases where medical reps carrying heavy bags, they develop SVC, the subclavian vein thrombus, pulmonary embolisms. So we should not miss that as well. And the causes, stasis, autoimmune vasculitic disorders, hypercoagulability syndromes, occult neoplasia is a very important thing, because the first episode of DVT pulmonary embolism could be the indirect sign, a red flag sign, a sentinel sign for an underlying occult neoplasia. So wherever possible, wherever needed, you can cone down the investigations. You need not send all the battery of tests, but wherever suspicions are there, you have to check up. If a patient has an obvious reasonable cause like a stasis, then of course the answer is there. But even then, even in those people, there might be an underlying proneness. We have to rule that out, because the identifying of these causes helps you determine how long you want to give the therapy. If a patient who had undergone a recent knee surgery develops a DVT, just you need not brush out and say that is an obvious cause. The same DVT, 1 or 2 days immobilization might have been causing DVT in the setting of, say, a factor V Leiden mutation or an APLA syndrome, where lifelong anticoagulation is mandatory, because the next episode might be the last episode for him. That's a very important thing. You have to cone down and see what it is. Recurrent left lower limb, if the DVT is happening, always make sure you are not missing May-Turner syndrome. It is nothing but a common anomaly where common iliac artery is compressing the vein. So they keep on getting this. If you don't tackle it by a venous stenting there, you will be doing a misservice for these patients. So the cause evaluation becomes very crucial. This is the classical case of May-Turner's on the left lower limb. Okay, once we identified the source and the cause, sometimes pulmonary embolism patient may do it, the legs might be free. All the clot has gone off, you might not find. Many a time it will be there. So how do you risk stratify these patients? Because unless you risk stratify, you don't know what all the therapy. The therapies we are told are 3 things: anticoagulation, fibrinolysis, filters, and of course the 4th one now is mechanical thrombectomy. 4 arms of treatment. Unless you know this risk, you need not always go in for a filter or a mechanical thrombectomy or thrombolysis. Anticoagulation is a bedrock. But to know who needs thrombolysis, you tell now. Aruna, you go ahead. How do you choose which patient needs thrombolysis?
So thrombolysis is only for patients who have a huge thrombus burden, mainly saddle thrombosis, and also when there is hypotension and also RV dysfunction. These are the three parameters where thrombolysis is indicated.
Very important, if someone has hypotension, he had a recent, almost like an arrest and then recovered, RV is dilated, RV dysfunction, positive trop, these are high-risk cases, you need to thrombolyze them. Fibrinolysis is a crucial part of therapy, you need not waste time, there are several ways of doing it. We need not put a catheter and give the thrombolysis, which might have some advantages, but as a general rule, we are giving the regimes what are given here. Antony, which regime is your favorite? Because we see this disease very common. This is not at all unusual disease at all.
As a FDA approved, we used to give Altiplace as 100 mg over 2 hours. But sometimes, same like MI, we used Tenetiplace also. As Dr. OIV is our favorite, like we used to give as a ultra low dose, as initial partial dose. After that, seeing any complication in the bleeding, then we will go for the next off dose.
So this fibrinolysis, the routine regime is 100 mg over 2 hours or 10 mg bolus 90 over 1.5 hours. In a rare case where high bleeding tendency is there, especially the paradox is you get caught with a post-op patient, a urology surgery, and the next day has a massive DVT with a pulmonary embolism. What do? Recent surgery done. And what are the options there, Raji? Because your center might not be having mechanical thrombectomy like we have. In our center, we do have access to mechanical thrombectomy where we can go in and use the special devices to suck the clots out. But even then, thrombolysis should be used in certain sick patients also. How do you go about there?
See,
Recent urology surgery.
Recent urology.
And then DVT. These are real life scenarios which we have seen.
We have had cases wherein the patient has undergone the surgery previous day and next day patient comes with DVT or in the hospital. They call us massive pulmonary embolism, wherein massive or catastrophic actually, wherein they need thrombolysis. So what we usually do is to discuss with the surgeons. There are few occasions surgeons will say, don't worry, if it bleeds, we will take care of the bleed, you proceed with the thrombolysis. But there are surgeons who will say, no, don't thrombolysis. That is when we will take them up for mechanical thrombectomy.
If it is not in a contained space like the cerebral surgery, spinal surgery, or other important intraocular surgeries, I think thrombolysis in a tailored therapy. Tailored, you need not go in for the full regime. As Antony was alluding to, you give partial dose, see the response, no bleeding, some benefit will be there, and you can keep on escalating the tailored thrombolytic therapy. And real life cases where the surgeons were bold enough and said, you thrombolyze, we'll take care of the bleeding because saving life becomes paramount. Tackling the bleeding is the next job, and fortunately we have been able to save many of them. Of course, we should be very, very, very careful about the bleeding and the medical legal aspects as well. You take the patient and the family into consideration and then carry out the job. So thrombolytic treatment is needed in such patients only. The low risk, the intermediate risk groups, RARV are normal, no dysfunction, hemodynamics is good, don't thrombolyze. There's no need for thrombolysis, anticoagulation is good enough. So anticoagulation, nowadays of course, apart from heparins, you also have NOACs also available. Vitamin K antagonists we are not using routinely. How do you choose your patients? Which anticoagulant is your choice? We have lots of choices there.
Initially during admission, we give low molecular weight heparin and then we switch over to NOAC. And we follow it for, when there is a specific risk factor, then we give for only 6 months. If it is, we couldn't find the risk factor, then we have to give lifelong.
So we have seen in our setting, this is a very common problem now. We are transiting to NOACs very, very early. Initial few days, 2 days or 3 days, even with thrombolysis or without thrombolysis, we give low molecular weight heparin, full dose, body weight. You can't subdose these patients, and then you go for NOACs. Antony, in our unit, you have seen we are using
we use apixaban very frequently. So with the thrombolysis, we have started already a low molecular weight heparin. If we give 3 days of low molecular weight heparin, remaining 4 days we will continue the apixaban 10 mg BD. Then after that, following that on discharge, we will give 5 mg BD. Depends on the provoking factor and provoking factor, we will decide on the duration.
So we are continuing, unless there is an extreme renal dysfunction, most of the times these drugs are good, especially the first 7 days with apixaban or the first 3 weeks with rivaroxaban is a double dose for a pulmonary embolism, unlike the other doses there. And then of course, there are still scenarios where vitamin K antagonist, acetylcholine, warfarin are needed. Raji, can you highlight about the APLA syndrome?
APLA, it's only BKs are recommended. Do not give NOAC in APLA. we have had patients who came with Novak in APLA case and who had developed catastrophic APLA syndrome, and she was very sick, of course. We could manage her. So what I'm coming to say is only VKA agent is approved or recommended in APLA syndrome, no Novaks. Other cases, in patients with moderate to severe hepatic dysfunction needing anticoagulation for DVT or PT, you have to use again BKA. All the Novaks are contraindicated in patients with moderate to severe hepatic dysfunction. Again, in CKD patients, when the GFR is less than 30, you can give apixaban 2.5 BD. If the GFR is less than 15, even apixaban is not indicated. So CKD, GFR of less than 15, BKA less than 30, apixaban. Otherwise, you can use above 30. You can use almost all BKAs.
So Aruna was telling that we have to use these drugs for 6 months. The guideline says minimum of 3 months, maybe usually 6 months, and then at 6 months you decide, can we stop or not? If it is APLA syndrome related, or if it is a genetic prothrombotic tendency is there, you cannot stop these drugs. They are lifelong. If the patient had one more episode, a second episode, it is lifelong. If the patient developed this DVT following a minor immobility, then you know that there must be something in. Go in deep and then evaluate, even otherwise give lifelong. Lifelong therapies, long-term therapies, after 6 months you can taper down the dose to half dose. This is a guideline approved strategy. So apart from this, there are some patients who will need filters, antiphospholipid antibody syndrome. It's a common problem which we should not miss. And nowadays, most of the hospitals, when you get any thrombotic tendency, we do APLA syndrome package, where a lupus anticoagulant, anti-cardiolipin antibodies, and antiphospholipid antibodies. And currently, we are also using APS. Yes, APS antibodies also are there. All four are being done together in one package. The venous filters. Aruna, I think we don't use routinely. Where do you want to use them?
Only in selected cases where there is recurrent thromboembolism and we are not able to give any Novak or VKA, then we have to think of IVC filter. Even when the IVC filter is put, we have to give a small dose of anticoagulation.
So this gentleman had developed GA bleed on OAC, the second day, massive GA bleed. So we had to go in, he was thrombolized, then OAC, then we had to put in IVC filter, stop those drugs till he recovered from the GA bleed, and then later on a low dose of Novak. This was a trapeze filter. So filters only for those where the anticoagulation cannot be given because he has bled somewhere till the bleeding is tackled, or you are giving the Novak in the correct dose, but they are getting recurrences. Or of course, there is absolute contraindication due to some other reason. Otherwise, we don't use them nowadays as a routine choice. And we also have two different types of filters. Retrievable, you can take it off after say 1 month or 2 months. Permanent, you can leave it forever. Of course, one should be careful. Those on filters can reduce the chance of pulmonary embolism, but they definitely increase the chance of DVT because stasis is there. So you have to give some amount of anticoagulation if possible in these patients. So this is it. The length of therapy is a very important thing. Patients with neoplasias are prone for this type of cancers. If a patient has active cancer, till the thing is sorted out, you have to put them on a Novak. Nowadays, one of the strategies is to give low molecular heparin for long. Apixaban, rivaroxaban are coming up in this area. GI tumors alone don't use rivaroxaban because more amount of GI bleeds are known. So this is a very important disease which will be underestimated and missed in the clinical parlance. Many a time, these patients come back after a week or 2 weeks of a misdiagnosis and then come in a very catastrophic scenario. This is a very easily diagnosable disease. I was talking to some of you before the program as well. This is a totally under-recognized entity. Thank you. Any parting remarks you want to highlight from your cases?
The thing is, one of the things is like MI, you can thrombolize till maximum 12 to 24 hours. In this pulmonary embolism, good effect till 48 hours and maximum you can thrombolize till 14 days also.
Correct.
So you no need to...
The mechanical thrombectomy is available in some centers. It is still an evolving technology. and probably with time it will be coming to more practical usage. Now the float retriever is undergoing trials in a very positive way. We have penumbra systems, lightning and all that in our lab. Not that useful as a routine practice. If at all we are doing it, we will be using only the rare case where thrombolysis cannot be done. And there also in some cases we are putting an IVC filter and then also doing the float retriever systems. After doing the sucking, we can put in the filter also and come out. This mechanical thrombectomy is a rarely used option. Surgical thrombectomy for acute pulmonary embolism is reported in some centers with aggressive surgical capability, but again, practically speaking, we have so many other options, and thrombolysis seems to be working very well in this scenario. Thank you very well. Thank you all. I think before you disperse, now the questions from the floor. See, this is an area, this procedure will take exactly 1 minute. In fact, I had one of the largest series in the country long back. Now the incidence has come down, we are not putting it in the patients. It just takes 1 minute. You just have to put it into the vein. Just make sure that the lowest renal vein is identified by one injection to the same catheter, and you withdraw the sheath, the thing will open. So this is a procedure done originally by a lot of cardiologists because we are pan-interventionists. In fact, we call many of the cardiologists are actually pan-endovascular interventionists. We do aneurysms and everything, but nowadays, as radiologists are getting trained, they are coming into this space. Probably it is purely a radiological technique in the future, going to be like that. Yeah, ECG, as Aruna was telling, S1Q3T3 for trainees is a very not much useful term at all. I think the most important thing is clinical suspicion, go and do a good echocardiogram. And if you have any suspicion, CT pulmonary angiogram, because it is available so widely now. If you're in doubt, double rule in. There are some cases where you are still doubt about even a possible aortic dissection or acute aortic syndrome, do a triple rule in, rule out. For the CT radiologist, it's such a simple job. Triple rule in, rule out, and you can treat the patients very well.
Sinus tachycardia is more common. Many a time when patients comes with significant dyspnea and you are not seeing any STT changes other than only tachycardia, there is no significant anemia, hypertension is well controlled, please think of pulmonary embolism.
High probability of index of suspicion, because there will be cases with submassive or even small multiple pulmonary emboli, which will not present the features of RA-RV dilatation. ECG will be normal, only CT pulmonary angio will pick up, and these patients also need to be treated very well because the next episodes, if you don't diagnose, are going to be massive pulmonary embolisms.
What did we say?
I think only hypoxemia can be treated. It's a very good point. I think Aruna, you can tell on that. It's a very crucial test in the initial part. Why?
Some of the patients on resting room air, saturation may be normal. Such patients, we have to make them walk a little bit. On exertion, we can bring about the saturation may drop below 80 or below 70 like that. In that case, we have to think of pulmonary thromboembolism.
So what Professor was telling is, in cases where there is a fairly good hemodynamics, but there is hypoxemia, you know that there is an oxygen, the perfusion and the oxygenation mismatch. So that's a very, very important pointer for those clinicians who don't have access or as a first step. Low saturation of SaO2 is a crucial finding. Yes, sir.
And whenever we are going for the post-op monitoring, when they are calling for cardiologist or physician, patient is having desaturation or having tachycardia, people used to think maybe some anxiety is causing that and all. But when we need to be very careful, we need to do a urgent echo, and we need to see is there any RA or dilatation. So we got so many patients like that pulmonary embolism in post-op patients.
Prevention is very
even
important.
in medical ICU, the commonest mortality is due to pulmonary thromboembolism. So most of our patients were on low molecular weight heparin to prevent the DVT.
Any more questions?
Measure and CT scan and other things. But pulmonary embolism is something which is you have to buy time, and treatment is immediate, which will bring back to life. So I have come across a patient who was discharged from the ICU for having taken a sheath put for pacemaker was temporarily given for propranolol excess, and he went into bradycardia. So temporary pacing was done. Within 2 days after the correction of it, the child was discharged home. Just 22, 23-year-old boy who took propranolol. Thereafter, coming home, within 2 hours after coming home, he went into syncope. He fell down. And he climbed 3 stairs with the other children and fell down massively. And we found that in between, he is going into syncope and, unconscious and recovering. The immediate intuition that told me was, this could be pulmonary embolism. When I was
Exactly.
called to.
Exactly.
And within 30 minutes, we rushed him to the casualty JIPMA where they did CT scan, and it was a massive saddle pulmonary embolism, which was, bolus of streptokinase was given.
It's very important that we give DVT
Yes.
prophylaxis for all these patients.
Yes.
Whoever is on the bed for anything more than 6
So I want to
hours,
say,
we have-
anyone who is discharged from ICU falls down when they reach home, please rush them back, because that is only going to be saving them.
good hydration and DVT prophylaxis for all patients who are coming for even minor procedures. We have seen patients undergoing cystoscopy, hernia
And it's
surgeries
also
coming
my
with
earnest request, please do not be in a hurry to discharge patients also like this. The child was removed of the sheet just that morning.
See,
The femoral catheter
see,
was
one of
removed.
the-
And within 4 hours, he is discharged because they wanted bed.
So one of the myths
you know,
is,
my-
So this was the cause of the pulmonary embolism,
Yeah.
rather than the treatment which saved
see,
him.
Raji, one of the common myths, people think that you need long air travel to get DVT. You tell our experience.
2 hours.
People going 1 hour to Pondi for 2 hours. They
1
get
or
this
2
problem.
hours is sufficient. Sometimes
There
they
must
will
be
have
some
other predisposing factors like some fever, dehydration. They wouldn't have taken enough, hydration, all that, or obese. So many conditions. Without all this, also we are seeing patients. We have had, I think, in our hospital highest, series of pulmonary embolism treatment. So we can enumerate any number of
You're
stories
doing
about
great, ma'am.
pulmonary embolism.
Also, I have a doubt. That child was put on acetrom, not any of these NOAs, because
Yes, yes.
monitoring was difficult. They could do only PNRI.
See, the
Monitor
problem
only
with-
with
Yes,
prothrombin time. Therefore, only acetrom was given for him.
Acetrom takes few days time to act. That's also important.
So they
if the child
for
is
about only
discharged-
6-7 months he was given.
Oh,
Thereafter
6-7.
he was not given because he did not have any other causes for hypercoagulation or any other reason except that propranolol for which the sheath was put. I mean, the temporary pacemaking was done.
6 months.
6
child is-
months only acetrom was given, and the sir was telling, when you after pulmonary embolism,
Yes.
for a lifelong time also you have to put
check
them.
and see
So
whether
I have
Depends,
that
sir.
doubt.
there is a necessity for long-term, has to be assessed clinically,
He's only
as well as by the
23 now.
testing. And you must be aware that Serena Williams, the greatest Wimbledon tennis star, had a small ankle sprain, rest, small mini surgery, massive pulmonary embolism. Of course, she recovered, IVC filter, anticoagulation, she won the next Wimbledon championship. Thank you.